Good morning. On this video, I'd like to talk about the effective follicle size on natural cycle frozen embryo transfers. Yes, the rise of the FET, frozen embryo transfers. Oocytes in embryos are being frozen by vitrification in increasing numbers due to both controlled ovarian hyperstimulation methods chasing greater follicle recruitment, lots of pre-implantation genetic diagnosis where the biopsied embryos are frozen while the processing is undertaken, increasing levels of oocytes being frozen and for fertility preservation, and a lot of oocyte and embryo donation. All the cryopreservation requires the transfer of the embryos to the recipient in a separate treatment cycle or cycles, and that is managed to various extent to accommodate the clinical timetabling and the client needs. Indeed, recent news that an embryo frozen more than 30 years ago was able to result in pregnancy tells you that cryostorage is safe and may even be intergenerational. The paper I'd like to talk about today appeared just recently in Human Reproduction Open and looked at pregnancy and perinatal outcomes after modified natural cycle frozen embryo transfers according to the size of the dominant follicle on the HCG trigger day, from authors in China. This is an open access article, and a lot of the material I'm presenting comes directly from the article. Well, there are two basic regimens people use or clinicians use for frozen embryo transfers. The first one is a natural cycle where we allow a follicle to develop naturally, ovulate. Then we use the natural hormone things to control the endometrium. And then there's a second one, which is an artificial one, which is purely controlled by drugs, a bit like the pill, and where the transfer can be manipulated by any time to suit both the clinic and the client. The artificial cycle system has been used for a long time and still commonly used as is suitable for both anovulatory and ovulatory women. Furthermore, this protocol provides convenience for both patients and clinicians as it requires minimal monitoring and offers flexibility in scheduling embryo transfers. And in a really busy clinic that's doing thousands of cycles a year, this is a very important point. At this point, I'm going to stop and both welcome you and add a disclaimer. My name's James Danger. I'm an embryologist with more than 50 years experience, and these videos from my FertAge YouTube channel are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff and doctors. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor, and maybe to help in understanding the advice you receive. I hope it does help. And lastly, this page I've set aside in every video for a support of IVF Daily. So I'm just starting out. I haven't got millions and millions of subscribers, but I will. If you want to promote your company or clinical product, this may be a great place to consider doing so. You may like to recognize that in supporting this channel, your support may mean that an IVF client becomes a better informed client, and that's for the betterment of all. You can click subscribe or become a sponsor, or just make a donation to help others on their fertility journey. So, artificial cycles. So this protocol, as we said before, provides convenience for both patients and clinicians as it requires minimal monitoring and offers flexibility in scheduling embryo transfers. Nevertheless, the medications used in artificial cycles can be costly, and long-term estrogen supplementation carries inherent risks such as thromboembolic events. More concerning, though, is recent evidence has indicated that artificial cycles, which do not have a corpus luteum, is associated with increased risk of adverse obstetric complications, including hypertensive disorders, pregnancy, preeclampsia, and postpartum hemorrhage. These safety concerns are becoming so of concern that there is an increasing swing to a preference for using natural cycle FETs over artificial cycles in ovulatory women. So the aim of a natural cycle FET is basically to provide to mimic what happens naturally in the development of the uterus and the development of the ovary, follicle, and the endometrium. So the aim of the natural cycle is to create a corpus luteum which is this structure here. So this is the ovary. You can see follicles are growing. Here's a mature follicle. This is where they can measure the diameter. The egg is ovulated, and then the follicle, which was fluid-filled, now changes into a huge organ that's producing lots of estrogen and progesterone. It's called a corpus luteum. And if there's no pregnancy, this atrophies very quickly. But if there is a pregnancy, the corpus luteum continues to enlarge, producing huge amounts of estrogen and progesterone to control and manage the pregnancy for about 3 months until the pregnancy is able to produce its own hormones. So the aim of the natural cycle FET is to create a corpus luteum to provide an essential environment for implantation, and especially the pregnancy, since totally artificial cycles lead to pregnancy complications, and also it's just not natural. In natural cycle FETs, the management follows a path of allowing a single follicle to develop naturally, and once ovulation has occurred or has been triggered by HCG and it converts the ruptured follicle into corpus luteum, the luteal phase is allowed to progress naturally or can be supported. The luteal phase is important since it controls implantation, and if pregnancy occurs, supports the pregnancy until it is able to manage itself for about 12 weeks. What now appears to be the case is the corpus luteum also sets in motion conditions that somehow impact the final stages of pregnancy and birth, but as I understand it, those reasons are unclear. So does the size of the follicle impact the outcome of natural cycles? Well, in a natural cycle, we normally allow the follicle grow to about 18 to 20 millimeters. So follicle size is important because all studies suggest that the best outcome for pregnancy occurs when this follicle reaches about 18 millimeters. But they can occur naturally in smaller sizes, but increasingly rarer. Follicle size is measured by ultrasound by using a couple of different dimensions, and is liable to variation. And I'd like to point out that there is, as far as I'm concerned, there is no quality management system for scanners to demonstrate their competency. And so you have to recognise that when follicles are being scanned by nurses or ultrasonographers, they may well vary in their ability to do that. But notwithstanding this follicle size relates both to the quality of the egg and the maturity of the follicle to change activity from estrogen production to progesterone production to support the endometrium and future pregnancy. But in natural cycles, the oocyte is not used. It's allowed to ovulate and nothing happens. Ovulation may occur, but the oocyte is not fertilized. Although, hint, you need to inform the client not to have intercourse, since this spare egg may fertilize. It's happened to me, and it may happen to you. And sometimes you have more than one follicle. So, is the 18 millimeter follicle size still important? This paper says no. So let's go and look at the trigger time. In almost 14,500 cycles, an amazing number of cycles, the trigger was based on the LH and serum progesterone rather than follicle size, and was a standard 5,000 to 10,000 bolus dose. Progesterone and estrogen support was started 2 or 3 days later, and then embryos were transferred on day 5 for cleavage stage embryos and day 7 for blastocysts. The data was divided into 8 separate groups based on follicle size at trigger from less than 12 meters to 18 millimeters above. And the authors asked, what were the outcomes from studying the luteal phase from follicles normally too small to create a viable oocyte? Does the endocrine from small follicles impact on the natural cycle transfer outcomes? So, the characteristics. When the authors looked at estrogen levels measured it on the day of the trigger or on the day of embryo transfer, the estrogen increased progressively as what happens in a natural cycle, corresponding to the follicle size. So, in other words, as the follicle became bigger, it produced more estrogen, and that was demonstrated in the serum. However, the progesterone levels on the day of triggering varied significantly across the cohorts. The highest levels were observed in the groups where the follicle size was very small, followed by those increasing diameters, and was lowest in the largest follicles. In other words, as the follicle grows, less progesterone is produced and more estrogen is produced, and this is reflected also in the output of the follicle, but also the hormone levels that the developing uterus is seeing. And not surprisingly, when they measured the endometrial thickness, that was lowest with the group of the smallest follicles, and the highest endometrial thickness was seen in the largest follicles. And that's what you'd expect. And there's an interesting rule The minimum size of the endometrium was thought to be about 7.5, and even with the 12 millimeter follicle, the average endometrial thickness was 9.9. So outcome of the cycles based on follicle diameter. So the authors presented data to show the likelihood of a live birth did not show a significant difference among the 8 groups in respect to live birth rates. 37, 36, 36, 35, 37, 37, 37, 39 for follicle sizes triggering from 12 to 18. There was also no statistical difference in regard to the positive pregnancy test, the biochemical the implantation rate, clinical pregnancy rate, clinical loss rate, and total pregnancy loss rate across all the sizes. In other words, the authors could demonstrate no impact at all on the pregnancy outcome of any cycle based on the size of the follicle at trigger. And lastly, they looked at maternal complications, and they report that in comparison to the women in the reference group, pregnancies arising from other studies did not show any elevated risks in relationship to follicle size for gestational diabetes, hypertensive disorders, abnormal placentation, premature rupture of the membranes, and cesarean section. Pretty important. Their findings indicate that by providing an intensive luteal support program, HCG triggering in a modified cycle can be administered at various follicle sizes ranging from 10 to 18 millimeters or larger. And noting that the triggering ovulation at a smaller than usual follicle size was not associated with diminished live birth rates or negative perinatal or obstetric outcomes. So the wider implications of these findings, the current data suggests that with the administration of an intensive luteal support program, the HCG trigger can be given across a wide range of follicle sizes from 10 millimeters to 18. And this approach not only simplifies the patient monitoring, but also offers greater flexibility and autonomy in scheduling the date of embryo transfer. So the authors have produced a text in their paper which is meant for patients, and I'll read it out as they have written it. The frozen embryo transfers have become indispensable in the field of assisted reproduction. Instead of using artificially hormonally stimulated cycles for endometrial preparation, modified natural cycles use no pharmacological intervention except HCG to induce ovulation. However, regular ultrasound monitoring of the follicle sizes and the endometrial thickness is needed to ensure the optimal timing of HCG administration, and there is currently no consensus regarding the optimal time for this trigger. Due to the limited research in this area, reproductive physicians generally administer HCG when the leading follicle attains a mature size of at least 18 millimeters. However, as we've said before, a mature oocyte may not be essential for frozen embryo transfers. Moreover, awaiting the follicle to reach a maximum size increases the number of clinic visits, and the laboratory must be prepared for embryo transfers on any day of the week. And finally, they argue that this large cohort study indicates that when providing an intensive luteal phase support, the HCG trigger can be given across a wide range of follicle sizes from above 10 to 18 millimeters in modified natural cycle frozen embryo transfers. Ovulation trigger at smaller follicle sizes in this study was not associated with negative reproductive or perinatal outcomes. This not only simplifies patient monitoring, but also offers greater flexibility and autonomy in scheduling the data transfer. So I thought this was a really interesting paper insofar as it's broken many down of the taboos we have about inducing ovulation with small follicles. I still don't understand why the data has no effect, but there it is. It's fairly strong. Okay, so thank you for listening. As I always said at the end of each video, IVF is a personal journey that involves the actions of many. It helps to understand all aspects of this journey. I hope this information be of value, and if you like it, please tell others and subscribe. Thank you very much.